Okay, everyone. I think we could probably start. It's already 5 minutes past one. I'll be giving the talk today, which is on bronchiolitis, as clearly displayed. It's a pretty wide topic. When I was first assigned, I had no idea how wide it was. Pretty much covers every part of pulmonary medicine, really. So I'll start off with the disclosures. As expected, I do not have any. Hopefully, I'll keep working on that and something should come up. Now, the objectives of this talk is just to improve our knowledge and understanding of the topic. The goal, I will emphasize, is not to give you a detailed treatise on bronchiolitis. It's way too wide for that. Each single aspect could easily last an hour to go over. So I'll just start off with some basic regular anatomy, and of course, why not? What's a bronchiole? It's pretty much one of the last parts of the conducting system of the lung. It's a transition between the respiratory surface and the conductive system. Some part of it may be able to participate in gas exchange. They're pretty small airways, anywhere from 0.6 millimeters to 2 millimeters in diameter, and includes the following structures: some cartilage, some ciliated epithelium, smooth muscle, which is very important, and the regular cells of the gas exchange surface as well. In terms of the surface area of respiratory tissue, it accounts for the largest subsection, and it's generally a low resistant circuit until something goes wrong. I've included this little picture to show some kind of histologic reminder. In the upper airway, we have the columnar ciliated epithelium with lots of glands, and as you transition to the alveolar region, it just kind of like transitions. I already used that. It just kind of transitions to the gaseous respiratory surface. So the columnar epithelium may go to more like a cuboidal ciliated epithelium, and you lose the glands. Now I put this up just to remind us of what normal pulmonary tissue looks like. I'm going to be showing quite a few slides for those who are not very familiar with that. Now, what is bronchiolitis? Common medical terminology will tell us that it's inflammation of the bronchioles, but it's a very loosely used term. Anybody uses it for whatever they feel like using. Whenever somebody doesn't fit in any particular pulmonary syndrome, a lot of the time people say, well, he has some bronchiolitis. What exactly does it mean? It's actually clinical pathological diagnosis, covers a wide spectrum of non-inflammatory bronchiolar injury, primarily affecting the small airways. The histologic findings are very broad and may be able to fit into separate categories, which I'll explain in a few minutes. Now, if you did have a patient whose biopsies showed bronchiolar injury, it really means nothing. There are 1,000,001 things that can cause that. You have to have some kind of clinical suspicion on what exactly you're looking for and what exactly you're expecting to see with regards to that clinical suspicion. Now, the clinical features, I'll give like broad clinical features which would fit into all the categories. It pretty much depends on the etiology, and there are multiple etiologies which I'll get to later on in the presentation. It could present as an acute disorder, subacute, or chronic in some other causes. The physical examination is often non-specific. A lot of the time, it's actually normal. When you do have abnormalities, you will be able to find positive findings of what you would suspect to be small airway obstruction. The most common association is wheezing, but as we all know, not all that wheezes has a specific cause. There are multiple possible reasons why a person may wheeze. Of course, you would also find the associated physical findings of whatever you suspect to be the cause. So if you had a person who you thought would have some connective tissue disease, then you would find the other manifestations of that connective tissue disease in addition to the findings of small airway obstruction. PFTs as well are not always very helpful. Very well may be normal. More frequently than not, you may also have some obstructive findings and air trapping. Diffusing capacity may be normal or reduced depending on the etiology. So pretty much you can fit into any category of pulmonary diseases with the PFTs. It doesn't really tell you much unless you have other information to support what you're looking at. In terms of radiology, you're not going to see bronchioles on chest x-rays. They're only about 2 millimeters in diameter. So that doesn't quite help you. On CTs, the findings are varied. You might see some trim bud opacities and small nodules. But one of the most common findings that you would be able to appreciate would be some mosaic attenuation and air trapping, which you would need an expiratory CT to have more pronounced. Very frequently you order a CT just to see the pulmonary parenchyma, and you're not specifically ordering that CT to diagnose bronchiolitis. So more often than not, you probably would not be ordering an expiratory CT. So I included this picture just to show some trim bud opacities, which you would find in infectious and inflammatory bronchiolitis, and also to highlight the differences between a not so normal CT and an expiratory CT of the chest, which shows the dark areas of regional hyperinflation. Now, in terms of the histologic subtypes, there are different classifications. There's no real standard way to classify them. The first one I'd like to start with, acute bronchiolitis, which not necessarily is doesn't look like a histologic classification. It looks like a time-based classification, but it's more associated with infections. So it's one of the more common classifications. There's an intense neutrophilic and mononuclear infiltration around the bronchioles. Usually this is associated with viral infections, but it may also be associated with other bacterial, mycobacterial, and atypical infections as well. In terms of the timeline of this is something that you would usually find in a relatively acute infection, somewhere between a few days and maybe a couple of weeks. One thing to note is that when you get the samples for this subcategory, there's clearly no fibrosis. The injury has not had enough time to organize. Some of the time it does resolve, and some of the time it will progress to something else. Depending on when you see this patient, you might be seeing the patient when it's progressed to a more severe form of injury, and in which case you would have to kind of extrapolate back to the original injury that caused this. Often very difficult to do because some of these upper respiratory tract infections are not remembered or have long been forgotten. This subtype is associated with infection, like I mentioned. Asthma as well, but that's a different topic altogether, and I'll get back to that in a few minutes. You also have the constrictive subtype, which is associated with submucosal and peribronchiolar deposition of inflammatory cells, usually neutrophils. This is more, in terms of time-wise, this is a more subacute manifestation. It's often very patchy and focal in terms of the distribution in the pulmonary parenchyma. So depending on how you get these biopsies, you may actually miss the lesions. If you get a biopsy in an area where you have normal lung, you get normal tissue. You know, Chatstone will put it up there and say normal lung parenchyma. Doesn't mean that there was nothing wrong with the patient. It just means that you missed it. So what is recommended if you really suspect this is to get more like a wedge biopsy. it may be progressive, and a lot of the time when it starts off, it's unrecognized until the patient becomes very dyspneic. And by the time you're getting samples, the inflammation is more of a chronic inflammation, and you may not necessarily appreciate the profile properly. These changes for constrictive bronchiolitis may be reversible. Sometimes there's nothing you can do by the time you find it. You can no longer initiate any treatments that will help the patient. You can only manage moving forward. I included this just to show these histologic findings. If you look at the tissue in the middle of the picture, you're seeing the bronchiole, and on the surrounding edges, you're seeing the alveolar regions. There's a lot of inflammation in the walls of the bronchiole, very thick, which it usually shouldn't be. And there's some deposition and fibrosis of the intraluminal contents. So it's almost like the plexiform lesions of pulmonary hypertension, where you have like severe obstruction, but only in the lungs this time. This is another image with a similar luminal obstruction. So if you imagine that the lumen of this bronchiole used to be somewhere around here, and then now you have probably more than 90% obstruction of the lumen, there's definitely going to be some severe airflow obstruction going on with that. And in the average patient with small areas of airway obstruction, there might not be any symptoms. But if this is something that's really generalized, or somebody who had a very poor reserve, then this patient is really going to be functionally limited. And this is a late stage of constrictive bronchiolitis, where the lumen of the bronchiole is completely obstructed. There's no airflow period going through. At this point, you begin to get a lot of air trapping distal to this, and sometimes you may actually have some cystic lesions distal to this. Okay. Now, constrictive bronchiolitis is thought to be rare and has most frequently been described in connective tissue disease. It's usually a progressive disorder, because by the time you have that degree of inflammation and fibrosis in the bronchioles, you're not going to get any resolution. It's pretty much done. You usually have a better prognosis if not related to connective tissue diseases. I've put in some common causes. Pretty much there are lots of diseases that can eventually lead to constrictive bronchiolitis. But if you see, everybody has seen patients who have these disorders and has not thought of bronchiolitis as the cause of their symptoms. So it's something that can happen in lots of disorders, not necessarily very specific to any singular disorder. Okay. So you have another subtype, which is the chronic bronchiolitis with fibrosis. In this case, it's a little bit different from the constrictive bronchiolitis, because here you have fibrosis around the bronchiole, but there's a lot of epithelial sloughing and hyperplasia involving the adjacent alveoli. There's a lot of similarity, and there's a little bit of a difference. Like I mentioned initially, there's quite a bit of overlap in the histology of bronchiolitis. I guess depending on the pathologist reading the slides, you could go sometimes one way or the other, as with lots of other disorders. And one of the other types is something that's likely to be very uncommon around here. It's very common in Japan. It's a rare disease even in Japan. Affects mostly men who are between 40 to 50 years of age. Slow onset, insidious onset of shortness of breath with progressive worsening. And of course, if you don't suspect it, then you're not going to find it. Most patients also have other respiratory manifestations as well, such as chronic sinusitis, and have frequent sinus infections. The exact cause is not known. In this kind of situation, you would generally suspect that there's some rare genetic disorder or immunodeficiency kind of syndrome. The exact cause is not known. The histologic findings are of bronchiolocentric inflammation and lymphoid hyperplasia around the bronchioles with formation of foam cells. As with other subtypes, there's a lot of histologic overlap. There is no known effective treatment, and about 30% will die within 10 years of diagnosis. This is, if you look at this slide, you could also make the argument that it's similar to the constrictive bronchiolitis picture, but in this case you have like focal areas of lymphoid hyperplasia surrounding the peribronchial tissue, minimal involvement of the alveoli as well. Now, we finished talking about the histologic subtypes, and I'm going into some bronchiolitic syndromes. One of the first ones and more common ones, I'm sure which we're more familiar with, is the infectious bronchiolitis. This is usually a more common syndrome in children associated with viral infections. It's not something that you would see very frequently in adults. One of the most common associations is with RSV virus. However, you can have it occur with other viruses, influenza, parainfluenza, and rhinovirus. You can also have it occur with mycoplasma and some other atypical bacteria. The symptoms are usually relatively mild, and may often not be something you would ordinarily visit the doctor for unless it's severe. Just some upper airway congestion, rhinorrhea, some fever, some cough. Nothing too exciting, really. Examination findings, non-specific, associated with a viral syndrome. And in very severe cases, very rarely, there's some oxygen desaturation and cyanosis, but respiratory failure is uncommon. It's not something we would ordinarily worry too much about unless the patient presented and got evaluated for it. Chest x-rays may show some hyperinflation, but this is not a reliable aid in diagnosis. You could have that pretty much in any other obstructive lung disease. And as we previously discussed, there may be some air trapping on chest CT. Now, PFTs for this syndrome are hardly ever done, because if somebody showed up to your clinic and said, hey, I have a cold, you don't exactly take them to the PFT lab to go get PFTs. You know that if they come back abnormal, that's what you were expecting anyway, so you wouldn't. For the same reason, you wouldn't really, at this point, be going with invasive investigation, because the common thought would be that this would be an upper respiratory tract infection. It will be self-limited by itself. You wouldn't chase that down normally. If biopsies are done, it just shows some peribronchial inflammation similar to the acute bronchiolitis histologic subtype. Just some mononuclear infiltrates around the bronchioles. And this is just another slide showing the obstructive findings that you would have. Sometimes what would happen is that after the acute phase of this acute infectious bronchiolitis picture, the intraluminal obstruction would resolve without any consequences, but it may also often progress to a constrictive bronchiolitis kind of picture with permanent obstructive changes to the bronchioles. Excuse me. In terms of treatment, you really wouldn't do anything most of the time because it would resolve. Now the question, when I did look at this, I looked into some of the chemotherapeutic agents. More often than not, when patients come to see us in the clinic, the first thing we reach for is some albuterol. And apparently there's really no evidence for that. It doesn't help at all. With your albuterol, it will probably take 7 days for it to resolve. Without albuterol, it will probably take a week. It will go away on its own. And we do have evidence for that because there have been studies that have shown that there's no difference with the use of bronchodilators with any of the endpoints that were measured. Length of illness at home, need for hospitalization or length of stay while hospitalized. Some small studies did show some decreased illness severity scores, but these were studies that were done in the 50s and 60s, and they were later discredited. So due to the meta-analysis that was done, there was no specific recommendation for use of bronchodilators, even though most authorities in the area would recommend that you try it. If they feel better, great. If they don't, then too bad, we just have to wait. Now, I went into some other chemotherapeutic agents. I kind of summarized them in this table, just because to talk about each one individually will take quite a long time. So bronchodilators, we already know no significant benefit. In fact, some of the studies that were done did show a harm just by tachycardia and tremors and other small side effects that don't necessarily cause too much trouble. There's no benefits to systemic steroids either. You just have to wait it out. Antibiotics, no benefit. And ribavirin, for patients who were diagnosed with RSV bronchiolitis, there is no benefit to the non-immunosuppressed patient. And even for the immunosuppressed, the evidence is not very strong. It's just recommended because you have nothing better. I kind of left out the flu treatment for influenza. And if I looked into the studies for approval for Tamiflu, and actually the benefits of use of Tamiflu are actually not very strong. He only reduced the length of stay from about 7 days to 6.3 days. Not terribly exciting, but it's probably better than nothing. For people who are sick enough to need hospitalization, I think it's probably reasonable to put them on some medication for flu. Now, bronchiolitis and asthma. I think one of the common things we've heard is that if you have childhood bronchiolitis, then later on in life you tend to get asthma. Right, Dr. Morris?
I hear it a lot.
I'm sorry?
You do hear that a lot.
It's not true. Well, it's not known to be true. It's not known to be true.
Didn't say I believed it, I just said
Okay. So I looked into some of the information regarding that, and what I found was that a lot of the studies that talked about bronchiolitis and asthma, what they showed was that children who did have bronchiolitis in childhood often present with similar symptoms later on in life. But the definition of bronchiolitis at the early childhood was not really very standardized. Sometimes it was just somebody looked at them and said, hey, you have bronchiolitis. Sometimes they had microbiologic evidence to support that as well. The case definitions were very variable, so it wasn't really standardized at all. However, we do know that roughly about 50% of children who are diagnosed with bronchiolitis eventually develop recurrent wheezing in the next 2 decades of life. The question is why? Some long-term prospective studies have shown an increased incidence of asthma in patients who were diagnosed with bronchiolitis in early childhood. But as we all know, asthma is not a single disease with a single phenotype, with a single manifestation. There are people who have asthma and are walking around, never have any symptoms, never have any problems. In one study of children who were diagnosed with bronchiolitis in early childhood and followed for 10 years, those who were diagnosed with bronchiolitis were 2 to 3 times more likely to develop wheezing later on in childhood. Does that mean they had asthma? Not necessarily. They had wheezing. We know that those who had bronchiolitis in childhood had wheezing later on in life, but not necessarily asthma, because a few of the studies that were done did not show any benefits to the use of bronchodilators in these patients. So some of them had wheezing, but this was non-reversible with bronchodilators. Now, in another longitudinal study which was done, these people were followed for 19 years. That takes some extreme dedication. Asthma was 3 to 4 times more common in the study group than in the control group. In this study, they had supportive PFT data, lower FEV1s, FEV1 to FVC ratios. But if you looked at the raw data, the differences between their FEV1s was not really significant. It was lower, all right, but not significant. No clear pathogenic mechanisms have been identified. Most people think that if you did have bronchiolitis in childhood, what has happened is that there's a complex interplay between your genetics, the severity of your injury, and other factors leading to some bronchial hyperreactivity. Overall, no one really knows how this plays out. And this is kind of like a model which has been used to explain the relationship of bronchiolitis and asthma. But like I said, this has not been proven. It's kind of a complex interplay, like I said, with the environment, the age of the patient at early infection, the genetics of the patient, if there's a predisposition to asthma. In one of the studies that I looked into, the biggest factor to finding out if people would wheeze later on in life was actually if their mothers had asthma, which may be more dependent on genetics rather than the bronchiolitis. That might just be a red herring. Now, some of the limitations of this association is that while it seems like there's a clear association, were you going to say something? Okay. While it may seem that there's a clear association with asthma, many of the studies that demonstrated this in the past, a few of them were done in the 40s and 50s, 50 years ago, had very poor study methodology. But one thing I'll also point out is that not all that wheezes is asthma. Do these patients have some form of mild constrictive bronchiolitis from their acute infectious bronchiolitis in childhood that it's sufficient enough to every now and then cause symptoms, but not sufficient enough to manifest otherwise? We don't exactly know. So what I'm saying is that did they have leftover injury from their bronchiolitis infections in childhood that follows them till this day? Okay. So another syndrome that is kind of common that we have to keep in mind is bronchiolitis and connective tissue diseases. It's more common in lupus, Sjogrens, and rheumatoid arthritis, but most common in rheumatoid arthritis. Symptoms remain the same as any other cause of bronchiolitis, but what can happen a lot of the time is that you see a patient who has connective tissue disease with clinical manifestations of that. The first thing that comes to your mind is not necessarily small airway disease. You start thinking about all the big things, some interstitial lung disease, some pulmonary hypertension, and start investigating along those lines. But what they may have may just be dyspnea from small airway disease that limits their functional ability. In some patients, they present with dyspnea before the diagnosis of connective tissue disease. If you don't have a reason to look for connective tissue disease, you don't. So they continue with their dyspnea until 6 months later, 1 year later, 2 years later, they eventually present, or until somebody reinvestigates them. There's also an association with the management of their connective tissue disease with medications, which can cause a lot of pulmonary complications as well. The subtype that is fairly common in connective tissue disease is of the lymphocytic infiltration of the bronchiole submucosa. Many have the constrictive pattern and chronic lymphocytic inflammatory pattern. There are no clear recommendations to treat bronchiolitis in connective tissue diseases. A lot of the time it's actually not diagnosed because we're looking for other things. such as infection in patients who are on immunosuppressants or pulmonary hypertension, like I talked about. At the time of diagnosis, because of the nature of the histologic subtype, it may already be irreversible. So at that point, you just kind of like manage your connective tissue disease to prevent further deterioration. Rheumatoid arthritis is our most common culprit in terms of bronchiolitic pulmonary disease. As many as 70% of asymptomatic patients have bronchiolar disease on CT imaging. That's pretty high. That's 2 out of 3 of asymptomatic patients. That's even way more common than the things we look for. And 30% of asymptomatic patients will have severe obstruction on PFTs, just due to the severity of their small airway obstruction. Now, the other part of the story, and something that needs to be considered, is that patients who have rheumatoid arthritis, who have other pulmonary parenchymal lesions such as NSIP or coexisting bronchiectasis, the first thing that will come to anybody's mind if you saw a patient with connective tissue disease with bronchiectasis is that you would think that, well, their problem is bronchiectasis, which is a larger airway disease, so of course you would focus on that. Some of the treatments that are associated with their connective tissue disease as well may be the culprits. And in terms of the management of their pulmonary disease, you have limited treatment options. Nothing has really shown a sustained benefit, probably because by the time of diagnosis they already have severe permanent damage to the small airways. That should have read erythromycin. That's the only thing that has shown benefit in a small case series of only 15 patients. So it's not necessarily the best medical evidence in the world. Now, if you talk about bronchiolitis and Sjogrens syndrome, you do have a large lymphocytic component with possible associated LIP. The only thing that changes really is that you may have cystic changes as well on the CT, but also it responds pretty well to steroids. As many as 50% will respond completely with significant improvement in their dyspnea to short bursts of steroids. I'll just skip this. Now, the next group of disorders I'd like to talk about would be bronchiolitis and inflammatory bowel disease. It's apparently pretty common in Crohn's disease and in ulcerative colitis as well. As with some of the other causes of bronchiolitis, one of the first things you would think about would be immunosuppression. These people are immunosuppressed. The first thing that you would think about would be infection, especially when you see ground glass changes on CTs. You would always think first of infection. However, their problem may actually be some small airway disease. These patients respond pretty well to management of their inflammatory bowel disease. I did have a patient who came into the clinic with uncontrolled Crohn's, and by the time he got back on his infliximab, he was a different person altogether. I didn't diagnose him with bronchiolitis because I wasn't looking for it. But by the time he got back on his treatment for his Crohn's, he was much, much better. Bronchiolitis in the lung transplant patients. So it's one of the concerns in the lung transplant patient, especially after a year, when the infectious risk and immunosuppression, the initial intense immunosuppression is decreased. It's more often associated with chronic rejection, and usually patients who eventually, I think everybody gets bronchiolitis obliterans with age of their transplant. but may be diagnosed anywhere from 3 months into their transplant based on FEV1 compared to the baseline. So the baseline FEV1 is essentially their best FEV1 post-transplant. And the way it's done is that you're supposed to get 2 FEV1s 3 weeks apart and average them out. The problem is that a lot of the time you're not able to successfully get 2 good FEV1s. So what lots of centers do is that they choose the best and move on. There are lots of risk factors for bronchiolitis obliterans in transplant, and some of these common ones are acute rejection, infection, especially if recurrent with viral, bacterial, and fungal causes. Prolonged ischemia at the time of transplant may also contribute to that, just by the loss of perfusion. And one other thing which we may not necessarily usually think about is just the relative ischemia from the loss of the bronchial circulation, because you get enough perfusion from the pulmonary circulation, but perhaps there are changes that are not exactly supported that may have been better if they had both circulations, even though it's just about 2% of the pulmonary supply. Inadequate immunosuppression, especially patients who have compliance issues, and patients who have problems with reflux, aspiration and microaspiration. They are all risk factors for the development of bronchiolitis obliterans in lung transplant patients. This is kind of like a table just showing the different levels of different grades of burst depending on the FEV1 baseline. Eventually, everybody progresses over time. Now, another subgroup of bronchiolitis in the solid and hematopoietic transplant patient. It's a graft versus host disease manifestation, in which case you have immune cells attacking the native cells of the body. You would find other manifestations such as skin manifestations. Median time of onset is about 15 to 18 months after transplant, with manifestations of shortness of breath, decreased exercise tolerance. Examination findings may be normal, and PFT findings may be normal / obstructive as well. The most common thing you would find on imaging would be some ground glass changes on the CT, which when you're dealing with a transplant patient, one of the first things you would think about would be infection. And if you do eventually get biopsies, the common finding is of heterogeneous lesions and skipped normal tissue, which may not necessarily be helpful. If you're lucky enough to catch actual tissue which is affected by the bronchiolitic areas of the lung, what you would find would be the obliterative or lymphocytic subtypes of bronchiolitis. In patients who develop bronchiolitis, post-transplant patients who develop bronchiolitis, your treatment options are really limited because the only thing you can do is to increase immunosuppression. But if you increase immunosuppression, then you increase your risk of infection. So it's kind of like a rock and hard place kind of situation. But that would be the treatment, to increase your immunosuppression. Another cause of bronchiolitis would be inhalational injury. This would probably be more common than we would anticipate, especially being in an industrial part of the country. So it's very important to dig into what the patient's occupation was. And I did have a patient who had a presentation like this. It's common to have people who were involved in wars, who got exposed to chemicals in different wars, especially those who were in Vietnam and Iraq and Afghanistan. It's known to have occurred in World Trade Center respondents and chemical factory workers, farmers, exposure to pesticides. There are lots of chemicals in our world today that people get exposed to. These are some common ones. One of the more interesting ones was the diacetyl, which occurred in a factory, a popcorn factory. Who would have guessed? So pretty much any gas, any noxious gas, can cause like acute airway inflammation, which may resolve or may progress to a more permanent injury with associated findings. There are two phases of the acute inhalational injury. So you have the acute toxic effects, which are more related to the noxious qualities of the gas. Patient develops laryngospasm, airway spasm, hypoxic respiratory failure, and sometimes progressing even as severe as respiratory arrest. Symptoms may then resolve. However, some exposures will lead to progressive disease, and either of two things will happen. They will develop prolonged reactive airway disease, which may respond to bronchodilators, and or constrictive bronchiolitis. The management of these patients, you should actually observe patients who have severe inhalational injury for at least 48 hours, and then follow them in the months to years thereafter. I did have a patient like this in the clinic. He was an industrial chemist, a PhD industrial chemistry. He told me he got exposed to a chemical diacetylcyanate. He told me it was the most dangerous compound known to man. I don't know exactly what he was why he was working with it. I kind of took his word for it because I'm not an industrial chemist. But almost immediately after he got exposed to it, this was 20 years ago, he got diagnosed with asthma and had been on treatment for that moving forward. Over the past few years, his disease has progressively gotten worse. I will add that he was also a pretty heavy smoker. But when I was preparing this talk, I thought to myself, is it possible that he sustained some kind of inhalational injury from that exposure, and his disease progressed on top of that based on his cigarette smoking? I don't know the answer to that. It's just a thought. And of course, you should withdraw the offending agent if known. These patients also respond to a prolonged course of corticosteroids, and if you discontinue that too aggressively, they relapse pretty fast. In summary, bronchiolitis is a pretty ubiquitous, common disorder. It's often undiagnosed because we're not thinking about it. It's manifested by small airway obstruction, which is usually progressive. What we do more frequently than not is that the patient comes in with dyspnea. You find some obstruction on their PFTs. You either go one way or the other, COPD, asthma, and that's it. We don't quite think of bronchiolitis as frequently as we probably should. Most of the time, the treatment is of the underlying cause, if you find it. And that's the end of my talk. Any questions?
Tony, you mentioned that the Japanese pan bronchiolitis.
Yes.
Unresponsive treatment.
Correct.
Did you come across, and I recall a couple articles in Chest a number of years ago, where they claimed that chronic macrolide therapy was beneficial in that. Did you run across that at all?
So there is a small pool of patients that there's a claim that it has been beneficial, but those patients were followed up to 2 years. But if you follow the natural history of the disorder, 30% will be dead in about 10 years. So they kind of like ended their study early.
Gotcha.
And so therefore they can say, yes, it was beneficial.
You mentioned another thing too, because Katie and I just saw a patient recently of hers, post-transplant rejection looked like occurring after an RSV infection, severe bronchospasm, asthma-like picture, treated for the last, couple months now, corticosteroids. Long time, but the thing was, the point I'm making though is her spirogram just came back to normal. And you said that these usually, I mean, I was actually asking Katie to look that up. You might know the answer coming across your stuff. I mean, do these patients come back to normal? Because myself in my own practice, I don't think I've ever seen it. Here's a patient after months of steroids you had him on, normalized spirometry. And yet your slide basically said also that it's like an irreversible process.
Now you're talking about a lung transplant?
No, she had a bone marrow, and she developed a RSV, then like a rejection type phenomena. We thought going on in lungs, low diffusion, really severe obstruction. Was fairly refractory there for a while, but after big dose steroids, then it basically spirogram reverse. So I guess my question is that, well, if this is irreversible, then maybe this was more of an asthmatic without actually rejection to be assumed.
She was on like 60 milligrams for like the 2 weeks.
Right, but she reversed those spirometry. So I mean, you said it's irreversible. Tell me what you know, what you found out about.
So what I came across was that for patients who have transplants, who develop bronchiolitis or small airway obstruction from the rejection of their transplant, the graft versus host disease. What transplant did your patient have? I'm sorry. Bone marrow. Okay. So who develop obstruction from the graft versus host disease? If you increase their immunosuppression, they can get better. But if it's already progressive to the point where it's where there's some obliteration of the bronchioles, then you're pretty much past the point of no return at that point. The problem with increasing their immunosuppression is that when you do that to be more aggressive with their graft versus host disease, you then predispose them to a lot of infection. So I did come out across some information that says that they actually recover back to normal if you do it early enough.
Bronchiolitis just from the infection in and of itself, then she just cleared the infection. It just takes some time for her airways to clear, as opposed to being that she has OB.
Valid point that we discussed, and she was still really abnormal like 3 months later. That just got residual asthma after that.
Yeah, it was almost 3 months after the RSV that we saw her, and she progressed to decline.
How much steroids was she?
Huh?
How much steroids was she on for increased?
Well, she was on none until we started her. At first we thought it was like maybe an asthma type picture, but she had issued asthma. She didn't change her spiral whatsoever on like 20, 40 milligrams of asthma or prednisone for like a week or two.
Probably longer than that, I think.
Yeah,
actually,
probably. But then we bumped her up to 60. We're really aggressive with a very slow taper, and she like has now returned to normal. There's been a couple times she's stopped her steroids, and she's declined once again. And she feels really well because that's the other thing that kind of goes with loss. Is initially she was symptomatic, but when she takes some of these dips in her spiral, and that's kind of part of the problem, she's not compliant. She doesn't feel it that well, and kind of fits more with the boss how there can be asymptomatic, some of their decline their spiral initially.
So Lisa might be right. We just weren't sure.
Yeah, no, we weren't sure, but
It was an awful unresponsive asthmatic for a few months. So.
Any more questions? Yes, sir.
In your extensive review of bronchiolitis, did you come across any of a lot of people who were exposed to the dust, in particular from that part of the World Trade Center, developed symptoms that would suggest bronchiolitis? Did you read anything?
I did find that. There were people who were exposed to the debris from the World Trade Center crash, but no one knows exactly what they were exposed to because, of course, it was all mixed with lots of stuff. But a lot of them developed progressive disease